these are very important data because this is the most common form of breast cancer in the United States and developed countries. And the most challenging decision we make with these patients is whether or not to recommend adjuvant chemotherapy with all of its side effects and with its potential benefits. And for those of you who have ever been a clinician in a consultation room or a patient in a consultation room, you know there's a huge difference between saying, well, you might benefit a little bit, and saying, there's no benefit for you. And what the data provided here today from this massive NCI-sponsored trial show is that the vast majority of women who have this test performed on their tumor can be told that they don't need chemotherapy, and that can be said with tremendous confidence and reassurance. Now, it must be acknowledged that over the past 12 years, we've been using this test on a day-to-day basis. So you might ask, why did we need this investment to validate that experience? And I think it's important for several reasons. First, the original data for use of the Oncotype DX recurrence score were based on chemotherapy regimens that were 25 years old now. And so the question has been, if we use modern chemotherapy, would the results be different? Secondly, we've improved our endocrine treatments, our anti-estrogen approaches, which also might have affected these results. Third, it's important to have a prospective validation of the data. And finally, there was a gray zone, an intermediate zone, where it was unclear what the magnitude of benefit for chemotherapy might be, and this created practical decision-making challenges for patients and for clinicians. So as you just heard from Joe Sparano, the results are clear. For almost all women who have tumors with recurrence scores less than 25, there will be no role for chemotherapy. There will be discussion for the small group of women who are less than age 50, who have intermediate range recurrence scores on the order of 20 to 25, as to whether they need chemotherapy or whether using an alternative endocrine approach, such as ovarian suppression, might accomplish the same goals. That leads me to the point, which is this is not so much about de-escalation, which is a phrase that many of the media had picked up on. The goal of this study was not to just use less treatment. The goal was to tailor treatment. They chose the title very aptly, with the idea of saying some women are going to need more of one kind of therapy and less of another, and others will get a different treatment based on the biology of their tumor. So this is an extraordinary day for breast cancer doctors and for women who have breast cancer. It allows us to individualize treatment based on extraordinary science, which now has tremendous prospective validation, an investment I would again echo, supported by the National Cancer Institute. There will be questions moving forward about how we can extrapolate these data to higher risk women and to other assays that have similar results. But for today and for the weeks to come, it's a very powerful finding. And in listening to Joe, I just wanted to make one more point, which is that even in the highest risk group of patients here, the ones who got chemotherapy and hormone therapy because the Oncotype scores were in the high range, the 10-year disease-free survival was 87%. We've made extraordinary progress in the way we are managing breast cancer. In the low-risk group, the 10-year recurrence rate is less than 5%. So women with breast cancer who are getting modern therapy are doing extraordinarily well, and this test shows us how to tailor that management so they get exactly the right amount of treatment, not too much and not too little.
Thanks, Hal. Great comments. I just wanted to add two things. We talk a lot at these meetings about diagnostic tests and whether they're well validated or not. And the series of studies over many years now, culminating in TAILORx, all performed using the Oncotype DX test, I think is a paradigm for how diagnostic test development should be done, going from sort of retrospective analyses of completed clinical trials all the way through now to a large prospective randomized clinical trial that shows such a definitive and important role for this particular test. But I'm not talking so much about the test itself as about the process, which I think is important to keep in mind. The other thing I just wanted to say, because I just would be remiss if I didn't say it, this study, as you heard, was initiated by the Eastern Cooperative Oncology Group, ECOG, and I would be remiss if I didn't acknowledge the key role of my good friend and colleague, Dr. Bob Comas, who was the group chair of ECOG when the study was conceived, who was a driving force in bringing it to fruition, and who sadly passed away last year. But this is such an important part of Bob's legacy.